So we have Mayan back again, and we're going to be talking first about targeted therapy, and then we'll get into non-targeted therapy, particularly immune therapy. And why don't we just start out with a case? Mayan has a patient, a 67-year-old woman he wants to tell you about.
Yeah. It's a really pleasant lady, 67, non-smoker. She presented with shortness of breath and had workup showed that she had left pleural effusion and a left lung mass. She also had a liver lesion at that time when we did staging workup. She did get a biopsy of the liver lesion, actually, because we figured if it's metastatic, then why go after the lung? And it did show adenocarcinoma. I did do NGS on her, and it showed EGFR mutation with exon 18. It was G719S. She did have a PD-L1 expression of 20%. So part of the workup, I also brain MRI. Unfortunately, showed multiple small lesions. She was asymptomatic at that time, no edema. So I mean, that's a variant that we don't see often. Mm-hmm. So I guess my first question is like, what would you treat her with that variant? I mean, I like osimertinib. Usually I go with it, especially with the brain lesions. I feel like might have better results.
I agree with you.
Could I just ask if she did require, if she were going to be radiated, she'd have to get whole brain?
Right. So she was asymptomatic at that time.
Right.
We did consult with
if she were,
okay. Right. Yeah.
It would be good. Yeah. So again, what do you think about the exon 18 G719S and this clinical scenario?
Yeah, so it's like you said, rare. I think it's maybe 1 or 2% of EGFR mutations. In terms of the label, afatinib is the only one that has that atypical EGFR mutation label, but I'm exactly in agreement with you. I think with the brain metastases in particular, I would do the osimertinib.
Yeah.
Ibiayi?
I would agree. I tend to agree. There's kind of an emerging literature here now, I think kind of led by MD Anderson, John Haymack's group, really trying to characterize these into whether or not they might respond more to a second generation like afatinib versus a third generation like osimertinib. But in these cases, I reach for osimertinib for the reasons you've outlined.
And to his question, like she's asymptomatic, she does have multiple brain lesions. Would you start the treatment and wait, see what she does, or would you just go with radiation?
Oh, I think for the driver mutation positive lung cancers, I don't think that there's a clear survival benefit with the radiation up front. So I would definitely do a short trial, 6 to 8 weeks of the TKI, and then repeat the MRI.
So you're going to follow up with what happened?
And that's what we did. We did like MRI every maybe 6 to 8 weeks just to make sure it's not like growing. We get like surprised with it. But unfortunately, she did have a partial response on her first PET scan. But then she got weaker and ended up in the hospital. She has nausea, vomiting. So they did a brain MRI, and the lesions were growing at that time. So that was around maybe like 6 to 7 months after she started osimertinib. So. What would you? I mean, she does have a PD-L1 expression, but I know after osimertinib, our EGFR mutations, PD-L1, immune therapy is not that effective. So what would you do now for her? What second line treatment would you do?
But and also in terms, she had, as mine was mentioned, has a PD-1 level of 20%.
20%.
Does the idea of not seeing response to PD-1 and EGFR apply to this particular thing, EGFR 18? It must be so rare. I don't know if we have data on it in terms of IOs.
Yeah, I think I would say that we don't have as much data, but we do tend to lump it together with kind of the classical and kind of our canonical EGFR mutations. I think one idea that I would like to put out there is that it's, for the most part, patients don't respond to these therapies, but there are retrospective data showing that some can. But in my clinical practice, I tend to omit the PD-1 or PD-L1 agent, in this case, and prioritize chemotherapy. And again, there's literature looking at whether or not adding VEGF to this can enhance the responsiveness, at least in a couple of prospective global studies.
No, I'm treating her brain. She's getting brain radiation right now. What I'm going to do, evaluate her performance status before I offer any other therapy, because palliative care is also an option, of course. Mm-hmm. Yeah.
Helena, where do we stand in terms of more typical EGFR mutations, patients who do have good response to osimertinib but then progress? in terms of second-line therapy?
Yeah, I think right now I would recommend, upon progression of biopsy, whether it's a liquid or a tumor tissue biopsy, about a quarter of the time we find something, whether that's histologic transformation or an acquired alteration that might be targetable, like MET amplification. So I would do that first. And then in terms of treatments after osimertinib, there's a few that we'll talk about that are emerging and likely to be approved, but chemotherapy is the sort of standard of care second line.
Without immune therapy, right?
Without immune therapy, correct.
So you talked about some new developments, and Ibiayi, I'm kind of curious in terms of where you see things heading in terms of this space, in terms of new approaches.
Yeah, I think it's whereas we tend to start, at least historically, with one strategy for most patients, I think this is really an area where we need to recognize the heterogeneity, do the biopsies, as Helena has mentioned, and really, as much as we can, remain precise or remain targeted. So if there's MET amplification, target MET. If there's some other alteration you can target, I usually tend to go in that direction. But I think something that we've seen emerge in this space is antibody-drug conjugates, right? Things like patritumab and other drugs.
So I did send for liquid biopsy. I'm waiting for that, but you also recommend a tissue if possible. I mean, she's still weak, so I just want to see how she's doing first. I thought about it because of the transformation.
Exactly. So liquid biopsy can capture a lot of things. There are some downsides. So depending on the volume of progression, sometimes amplification events aren't as readily identified. And I think the big thing you miss is histologic transformation. So you want to make sure it's not small cell or even squamous cell.
So, we want to give the Florida Cancer Specialist Docs the opportunity to query you, and that's the whole sort of message of this weekend is how helpful it is to ask questions to investigators. So here's some of our thoughts about that.
Great question.
It's a great question.
Yeah, so it's a good question.
I think it's a very excellent question.
Yeah, that's a great question.
So there's an excellent question.
Another really good question.
I don't know why we do these things, just have no idea at all why we do these things. Anyhow, why don't we bring in some more data, and then we'll come back with some more cases and questions from my end. And we ask Helena to talk about patients with EGFR mutant disease, including exon 20, where so much is going on.
Yeah, I have the pleasure of discussing a lot of new data over the last year. So we'll talk about... Here's my disclosures. We'll talk about, as we mentioned, the common EGFR mutations, so L858R and exon 19 deletion, and then we'll end on the exon 20 insertions. So I also have a case. So this is a 50-year-old never smoker. She presents with metastatic lung adenocarcinoma. She has a large pleural effusion, bone mets, liver mets, and she is quite symptomatic with shortness of breath. Her molecular testing shows an EGFR exon 20 insertion. What is the optimal first-line approach?
And do you care what the PD-1 is?
Let's say it's PD-L1 100% expression.
Wow, PD-1 100%.
Go big.
Mayan, you want to take a crack at that?
I mean, she had exon 20, so I'd probably go see. I'm not sure about the variant, though, but...
I don't see IO alone, but okay, well, tell us.
So I agree with him. I would do C, I think, and that's based on hot off the press data. I think it was approved March 1st. Chemotherapy plus the MET EGFR antibody amivantamab.
And in doing that, what do you anticipate in terms of tolerability issues for this regimen?
Yeah, so that is a great question, Neil. I think that
You already learned from it.
Great question.
Can't help it.
But I would reserve this regimen. She's 50, she's fit, and she's quite symptomatic. And so I would reserve this for someone that needs a response, who would be fit enough to tolerate it. If this was a 80-year-old, I definitely would not give this combination.
And what do you see with this combination in terms of tolerability issues?
Well, I think all of us are well familiar with the platinum-based chemotherapy, and then the amivantamab definitely adds to the neutropenia and cytopenias, but also brings on EGFR and MET-directed side effects. And so nail issues, paronychia, skin rash, and with the MET, you also see peripheral edema that can be quite severe and bothersome to patients.
Yeah, Ibiayi, maybe you can kind of relate your experience with amivantamab, and again, more about the edema. I couldn't quite get the feel for that.
Yeah, so when you target MET, it's a class effect that you can get edema, you also get hypoalbuminemia, and so we see that. But I would say in clinical practice, the EGFR toxicities that tend to be the toughest, the skin and nail toxicity. And one that's worth noting is a hypersensitivity reaction that we see in about 2/3 of patients, happens pretty early, so your infusion center has to be aware of it.
Interesting.
How long would you give it for? I mean, let's say she has very good response. Would you keep her on PEM and
Yeah.
maintenance?
I think that's also a good question. I don't think we have the data in terms of kind of when to stop it, but I do agree with you that we talk about a lot of combination therapies for first-line treatment. I think that induction period is the key period where we're trying to wipe out as much residual disease as possible, and probably the continuation is less of an important factor.
How about what comes next?
Post chemoamy, the challenge with these things is you wiped out 2 lines of therapy in one, and so then you're really looking at, for someone like her who PD-L1 is 100%, you could think about some immunotherapy, but probably would be second-line chemo in terms of standard.
And do you really not ever see responses? I think I've heard about responses. I don't know, Ibiayi, do you never see responses to IOs with EGFR?
I would say more often than not you don't, but you can see them, right? And I think that's why there are people we might give it to, right? But I think that you would exhaust all your, not for exon 20, but for others, you would exhaust all your EGFR TKIs. I tend to exhaust all other therapies that have proven benefit before reaching for that.
But do you ever see like a prolonged IO type thing?
I have not personally in my clinic.
I would say just, in terms of prospective data, UCLA did a really small but meaningful study of about 10 patients, EGFR positive, PD-L1 50% or greater, and gave them first-line pembrolizumab as monotherapy. None of them responded. There was one responder who turned out not to have an EGFR mutation. So we can't say no one responds, but it is a different disease, I think, with that EGFR mutation.
That is really amazing. All right, let's talk about this osimertinib data.
Yeah. So, I think that the benchmark in terms of typical EGFR mutations is osimertinib. Osimertinib is a third-generation, irreversible, mutant-specific EGFR TKI, so less wild-type EGFR toxicities. And the seminal study was the FLORA study, and the curves are here comparing osimertinib to earlier generation TKIs, and showed a clear progression-free survival as well as overall survival benefit. But even with this, almost everyone progresses and is in need of new treatment. And because of its success in the metastatic setting, this also was looked at in the early stage setting. So for patients with stage 1B, 2, and 3A EGFR mutant lung cancer with the common exon 19 deletion or L858R, after surgery and chemotherapy, if appropriate, were randomized to 3 years of osimertinib versus placebo. This is the ADORA study, which I'm sure you're all well aware of. And we've seen many updates of this data, but the progression-free survival is on the left, so marked improvement in progression-free survival, disease-free survival, and then also a very significant overall survival with a hazard ratio of 0.49, so quite impressive. And so thinking about how else we manage early-stage disease, if patients don't get surgery, they get radiation. We all know the PACIFIC data talking about durvalumab post-radiation, but what do we do for these EGFR mutant lung cancer patients? And so this is retrospective data, multi-center, that looked at patients with EGFR mutant lung cancer that got radiation and then either received osimertinib, off-label, durvalumab, or observation. And you can see that it does look like osimertinib consolidation therapy post-radiation did improve both progression-free survival and less so overall survival. And that leads us to the LAURA study. So the LAURA study is the prospective study looking at this. So patients with those common EGFR mutations getting either concurrent or sequential chemoradiation, getting after radiation being randomized to osimertinib versus placebo. And the difference with this is it's until progression, so it wasn't a set time period, but we just saw the press release in February last month that showed that there was an overwhelming efficacy benefit in these unresectable stage 3 patients. And so we expect to see this data at a conference soon. And so I think, as Ibiayi said, we want to personalize our treatment. And so thinking about two different types of cases, thinking about a 76-year-old with a common exon 19 deletion that is asymptomatic, thoracic-only disease, seems to be slow growing, versus in contrast, a 52-year-old with the same mutation we just talked about to start the session, concurrent mutations in P53RB1, high symptom burden, diffuse metastatic disease. Right now, we would think about giving both of those cases osimertinib, but you have to feel like there's something different about the disease and biology of these two cases. And so what can we do to think about risk stratifying and risk adapting treatment, and what treatment would be most appropriate for people who are lower risk and higher risk? And these are questions we're definitely going to have to answer. So new data that came out this year is the FLORA-2 study. This was long awaited because this was osimertinib versus osimertinib plus chemotherapy. There were studies of older EGFR TKIs where we knew that chemotherapy might lead to additive benefit, and so this was the prospective study. You can see that it was a very large study, more than 500 patients. I think important to note is that 40% of patients in both groups had baseline brain metastases. As we know, EGFR mutant lung cancer has a very high likelihood of development of brain metastases. Both treatments were relatively well tolerated. Of course, there's going to be more cytopenias with the chemotherapy combination. And here on the left, the big curve is the PFS data. You can see a 9.5-month difference between the combination versus osimertinib. When we think about combinations, we need to see either a sum of a PFS benefit that is greater than sequential treatment, or we need to see a survival benefit. That, in my mind, that's the threshold of using combination therapy. And you can see that the survival benefit, interim analysis did not demonstrate a survival benefit. But interestingly, a subgroup that seemed to benefit were patients with CNS metastases. And so we think of osimertinib as being very CNS penetrant, but it does seem like the chemotherapy added for that high-risk group, which is interesting.
Any thoughts about why? That seems kind of strange, actually.
It does. I think it's good to remember that chemo is also CNS penetrant. We forget that sometimes, but I think that it's something about whatever disease the TKI isn't able to eradicate, you're coming in with a different modality or sort of different mechanism of action treatment. But it's strange. It was surprising.
Ibiayi, are there situations right now where if you think about the two ends of the spectrum, on the right side, a lot of disease, brain mets, is that somebody where you might want to do this?
Yeah, I think that is the person, right? So a lot of disease brain mets, perhaps we'll get into this. There are different types of EGFR mutations too. And then the co-alteration sometimes can sway me too. So P53 mutation or other things that might be enriched in perhaps bad actor EGFR mutant lung cancer. I might pick a combo.
Mayan, any questions?
I want to actually present a case maybe because that might fit
Yeah,
you.
maybe just, we're holding off on, we'll keep going with your talk in a second.
problem.
We stop the timer. Keep going.
So this is one of my colleagues, Dr. Hart's case, and it's a 67-year-old woman, non-smoker. She was diagnosed with T3 and 2 adenocarcinoma late 2022, got chemotherapy and radiation. So she did have the EGFR. She had L861Q mutation, and did well after long consideration. They started on osimertinib. So they figured, let's go not do DARVA rather than DARVA. Had excellent tolerance, but then she had a recent PET-CT scan. Showed a slightly bigger level 4 thoracic node, some centimeter lung nodules were slightly active. Clinical state, she's feeling great, maybe just anxious. He's ordering another CT just to follow up on that, so he didn't change treatment now. But his question is, if this new CAT scan shows that those lesions are getting worse, so what will be the option? He did order a liquid biopsy, no EGFR in the liquid biopsy. It did show P53 though. So would you add chemo to OZ at that time? Would you, we don't have a trial at that time. So would you add chemo? Would you try AMI with chemotherapy, another option? Or would you add BEV, maybe with chemotherapy? Now, immunotherapy, would the immunotherapy be an option too?
Ibiayi, any thoughts?
Just wanted to clarify, it's originally a stage 3?
Stage 3, yeah.
That got added.
And instead of DARVA, they give OZI, but now like there's some progression.
Yeah, I think that it still remains, prospectively, we've not necessarily answered the question whether or not to continue the osimertinib in these cases. I tend to, if someone has had, and for classical EGFR mutation, if someone has had great CNS outcomes, they're not progressing at multiple sites, I think with an L861Q, I might think a little bit about whether or not this person needs to continue that approach. I would reach for chemotherapy for this patient if I did not have the opportunity for focal radiation to kind of oligo recurrent disease.
All right, let's go back to amivantamab and lazertinib in the Mariposa trial.
Right, so this also were data that were presented this year. So amivantamab, as I mentioned, is a MET EGFR bispecific antibody, and lazertinib is a third-generation TKI, so a cousin to osimertinib. And this study, also a very large study, more than 1,000 patients, really looking at amivantamab and lazertinib versus osimertinib with a small lazertinib cohort for contribution of components. And you can see that the groups were well matched. And then in terms of toxicity, as we mentioned earlier in the session, it's really the notable differences are the EGFR and MET toxicities. And here are the data for that combination. So also a really impressive about 7-month improvement in progression-free survival. They also presented interim overall survival, where it did seem like Ami-Laser did seem to be better than osimertinib, but again, immature data. And then the response rates were quite similar. So this would be another combination that might make sense first line. And so thinking about those two different cases, I think it's exactly as we've been alluding to. I think low burden disease, older, asymptomatic, the thought would be osimertinib alone makes sense, even though I forgot to mention the osimertinib and chemotherapy is now FDA approved as a first line treatment. And then maybe, we know L858R might do slightly worse than exon 19 deletion, or if there's more tumor burden, we could think about escalating care. But certainly for that more extreme case with the atypical mutation, diffuse metastatic disease, I would think about either osimertinib and chemotherapy or amivantamab and lazertinib as first-line treatment. And so we mentioned this as well, thinking about mechanisms of resistance to first-line osimertinib. You can see on-target effects, which are acquired EGFR alterations, off-target, new alterations, and then that histologic transformation, which is actually about 15% of the cases, so not so infrequent. In terms of options post-osimertinib, the one possibility, and it's all about sequencing. What we use first line will dictate what options we have in the second line setting, but one option is amivantamab and chemotherapy, and this was looked at, again, in people post-osimertinib, a large study, similar to the other studies we talked about. EGFR and MET toxicities are the notable. Although this, we talked about this, the combination is tough. They also tried to do amivantamab, lazertinib, and chemotherapy, and really saw an excess of grade 3 and 4 neutropenia and cytopenias, and actually had to amend the protocol. So we're focusing on the ami chemo as the viable option here. And here are the data for this, where you can see the quad, the AMI laser chemotherapy quad, if tolerable, sort of did the best, and then AMI chemotherapy followed by chemotherapy alone. But again, this would be in someone that had really robust performance status, and maybe someone that you really wanted a response, where we would think about the triplet. And then, I'm sure in this day we've talked about antibody drug conjugates, and so one that's been looked at in EGFR mutant lung cancer is patritumab deruxtecan, which is a HER3 ADC, and also looked at in phase 1, 2, and now phase 3 studies in the EGFR mutant lung cancer space. With ADCs, we see cytopenias and we see alopecia, because these are chemotherapy. I talk to my patients as if these are hybrid treatments, so a cross between chemotherapy and targeted therapy. And the response rate post-osimertinib and after platinum-based chemotherapy as a later line option was 30%, with a median PFS of 5.5 months. And I think an important thing to note is resistance mechanisms to osimertinib are quite diverse, but this did seem to work whether somebody had an EGFR C797S or a MET amplification. These ADCs, as chemotherapy, seem to transcend some of those mechanisms of resistance. And then finally, to end on the exon 20 insertions, rare, about 10% of all EGFR mutations, activating but not sensitizing to the classic TKIs. So for the past few years, we've had amivantamab, so it's another use for this, the MET EGFR antibody. Response rate about 40% as a single agent, approved in the second line and beyond setting, so after chemotherapy. And so because it looks to be effective in the later line, there was the Papillon study that looked at amivantamab and chemotherapy as first-line treatment for EGFR exon 20 positive lung cancers. And AEs are similar to what we've seen with the combination. And here's the PFS data. So this was actually, I think, surprised a lot of us in terms of the efficacy. The hazard ratio for PFS was 0.395, with AMI chemo leading to 11.4 months and chemo 6.7 months. And so, and this was recently approved within the last month, as well. So I think thinking about a patient that was fit, that had a disease burden, this would be a case where I might use AMI chemotherapy versus chemotherapy alone in the first-line setting. They did also show that that benefit of PFS was maintained after the first-line treatment, and overall survival benefit immature but trending towards the combination having benefit. So that's the EGFR section, understanding that probably still osimertinib is monotherapy would be our baseline, but if patients have high-risk features, would really think about one of those new combinations. We use osimertinib post-surgery in the early stage setting, and I suspect we'll be using it post-radiation in the early stage setting shortly as well. And then looking at some novel treatments, in particular amivantamab and patritumab deruxtecan post-osimertinib.
I have a question about the adjuvant.
Yeah.
So I know it's for 3 years, and I read somehow like that after you stop after 3, you do see recurrences. Do you think we need to extend, or just like with breast now, we're doing like 10 instead of 5?
I think
we're going to get
right?
there. Yeah,
I think you're right. I mean, I think when we look carefully at those curves, you see at the 36-month point, they start to come together. So I think that there probably are some people where a longer benefit might be better. There is a study ongoing now, 5 versus 3 years, and so we might be changing the duration.
Would you rely on
that.
ctDNA maybe in those patients? See, like if a clone starts coming back up?
I think that, there are those novel ctDNA assays that really can detect very tiny amounts of disease. If those become real-time and commercially available, then maybe we could
then we
use
know
that.
who will benefit
Exactly.
and who won't. Yeah.
I mean, you can have that theory, but I don't know about you. I was pretty surprised at the survival benefit with that osimertinib. The idea of the curves coming together and et cetera, et cetera. That was a pretty significant survival benefit. Ibiayi, were you expecting that? I think it was close to 0.5, right?
It was. Yeah, so I was expecting it, but at the same time, I also could not neglect the coming together of the curves. And when faced with a patient in clinic who's on these medications, who's tolerated it well, I think what I've faced is that the patients want to continue on it. And so I think that we have to have more sophisticated strategies, as has been highlighted here, to figure out who we can stop it for, because it can be a particularly financially costly medication to stay on lifelong.
A few cases from the audience. So Helena Hassan has a 40-year-old woman, metastatic adenocarcinoma lung, exon 21, single rib met, single brain met, no mediastinal disease, T1, N0, M1.
So that would be a case that, I would think about osimertinib, induction therapy, and then think about radiation as consolidative therapy. We know that for the right person, where all sites of disease can be targeted with local therapy, clearly improves disease-free and overall survival. And so Young would want to be as aggressive as possible, so would think about that.
In general, we were talking about brain mets in general with EGFR. What about the patients who could get SRS? Ibiayi, do you do it, or do you just give them the osimertinib?
I give them the osimertinib and then do a kind of a short interval scan and make sure that it's working.
How about in the adjuvant setting for EGFR patients? Do you think osimertinib or TKIs will have a role in early stages? Like now we do immunotherapy for neoadjuvant.
Oh, so you think about neoadjuvant therapy?
Right,
yeah, I mean, that I don't know. I mean, there's the NEO-ADORA study that will answer that. We saw interesting data last year at ASCO that osimertinib by itself didn't seem to have the same path responses as chemo or chemo-IO. So I think we'll see, but I wonder if the combination of chemo and osimertinib might be something that we'd use neoadjuvantly.
Ibiayi, here's another case from the audience. Shalini has a 64-year-old patient, EGFR L858R, started on osimertinib for 3 months, great systemic response, but now leptomeningeal disease, symptomatic with headaches. Options?
Yeah, this is a very tough one, right? And so leptomeningeal disease is one of kind of the most devastating kind of complications of having lung cancer. Osimertinib has brain penetration, but sometimes we do see like progression in the brain. People have tried escalating the dose of osimertinib to 160 milligrams. That was explored in the Bloom study for this type of patient population, but also looked at retrospectively in patients who progressed on 80. I think the consensus is that it probably modest benefit. It's something one can try, but I think we lean towards radiation here and kind of having prognostic conversations and reaching for chemotherapy.
Come back to me in a second, but another case, Helena from the audience, from Kathy, as a patient with EGFR G719S mutation who cannot afford afatinib or osimertinib due to high copays. Despite applying for financial assistance, she was able to get erlotinib. What response can be expected, and what other therapies would you be thinking about?
That's tough. I think the reimbursement and access to these have changed recently. So I think I still would do erlotinib. I think that although the response is attenuated with this atypical EGFR mutation, I still think that likely better than chemotherapy. But I would just be sort of on higher alert with scans and being on the lookout for progression. But I'd still do the erlotinib.
All righty, well, why don't we take a look at some data on other mutations outside of EGFR, and Ibiayi is going to talk about that. And I think we're going to start out here with a case, let's see, right, the 55-year-old lady. Yeah, this is interesting.
Yeah, so this was 2019, so a 55-year-old without a smoking history, had dysphagia, got a workup that showed a 1 centimeter left upper lobe lung nodule, did not have any other FDG avid sites on PET, had a really kind of largely unremarkable medical history. Because there's no other sites of abnormality, she actually went straight to the OR for both a diagnostic and therapeutic procedure. Ended up getting a lobectomy that confirmed a 1.6 centimeter adenocarcinoma with a single kind of N1 nodal involvement, so 2B. And she had molecular testing by her local oncologist. And so one can actually ask the question back in 2019, were we doing molecular testing in all these patients? But she had it, and she ended up having an EML4 ALK fusion. And she was referred to my clinic because we had a study that I'm going to talk about in the upcoming slides, the ALINA study. So she actually enrolled in ALINA at that time, and it was actually randomized to receive alectinib. And
What was the other arm?
Chemo.
How'd you feel about that? At that time, of course, again, that's 5 years ago, but still.
Yeah, how do I still feel about it? I think I actually think it's quite bold to leapfrog chemotherapy, but the patient was elated. I can tell you as a patient, she was happy to bypass chemo and go for a targeted option.
And I guess, a lot of people were predicting that it was going to be a positive study, and there it is.
Exactly. And so with that, we'll dive right into ALK-positive lung cancer, just for framing the context of the ALINA study. So when we think about ALK-targeted therapies, we tend to think of them in the stage 4 setting. And in current clinical practice, we prioritize various next-generation ALK inhibitors based on studies like this here, summarized in this table. These are global studies comparing to the predecessor of crizotinib, the first-generation ALK inhibitor. And with second-generation ALK inhibitors like alectinib and brigatinib, we tend to expect median PFSs of around 2 years plus. With lorlatinib, we haven't seen the median PFS. Lorlatinib, as a reminder, is a third-generation ALK inhibitor, but we think it's going to come in somewhere around 4, 5, 6 years. And so it's based on this kind of substantial activity of these ALK TKIs that the question was raised, should we be moving them to the earlier stage setting? And so this is the ALINA study. It's a global randomized phase 3 study that compared adjuvant chemotherapy to adjuvant alectinib. These are patients who had 4 centimeter or greater tumors or had node-positive disease. They were randomized 1-to-1, as we just discussed, to either alectinib for 2 years, so a little bit different from ADAURA, where you had 3 years in the EGFR space, or chemotherapy. The primary endpoint being disease-free survival by the investigator first, similar to ADAURA in a stage 2 to 3A population, and then in the larger patient population. And so these data were presented by Ben Solomon at ESMO in 2023. We saw 2-year outcomes and 3-year landmark outcomes. And there's a 30+% improvement in the disease-free survival rate at each of these landmarks. And at a little bit over 2 years follow-up, 12% of patients in the alectinib arm had an event versus around 40% of patients in the chemotherapy arm. So it really is an impressive drug, similar to what we've seen with ADAURA. This benefit was seen across the disease stages enrolled here, and so if we look at a 2-year landmark, over 90% of patients were alive and free from progression with alectinib, whereas that number was 60 to 70% with chemotherapy. And so this is an intriguing option for a therapy. We know from the stage 4 setting that alectinib is a well-tolerated drug, and so it wasn't surprising to see here that dose reductions were seen in about 1 in 4 patients, but 5% of patients ended up stopping treatment due to toxicity. Similar to what we encountered when we first saw the ADAURA data, I think we still have some remaining questions. Will this improved DFS translate to improved overall survival? And I think that this study was conducted in a way that I think we can robustly answer that question, in that 76% of patients who received chemotherapy went on to receive an ALK-TKI. So it's not an access issue here that we're looking at. At the same time, are we increasing the cure rate? And if not, like as posed earlier, is 2 years enough? Do we need to give people more than 2 years? Do we feel comfortable omitting chemotherapy? I tend to have a little bit of kind of internal turmoil about stage 3, right, and stage 2. And then can we apply this to patients treated with definitive chemoradiation and for unresectable stage 3? And this is being explored in the Horizon 01 study.
Incidentally, before you go on, when you say you're reluctant to not give chemo, I always have been kind of like not that excited about adjuvant chemo and non-small cell to start. I mean, the hazard rate is like, what, 0.88 or something? I mean, this is from like 20 years ago. So are you really that excited about it?
So excited is a tough word. So I would not say that I'm extremely excited, but there is a survival benefit, right? 5%. And when you get to stage 3, it's probably that population that we're helping the most. And I have not seen a survival benefit to date with alectinib, with an ALK-TKI. And so that's part of the reason for the tension.
So would you sequence, like do chemo first, then ALK?
On the record, I would do it as the study was written, but I think that there are for certain patients that I might think about, like, I would have wanted to give chemotherapy before I gave the ALK-TKI.
All right, let's talk about RET.
Yeah, so turning towards RET, this is one of 4 molecular subsets we're discussing today. So RET, the landscape, like we kind of welcomed RET into the targeted therapy landscape a couple years ago with FDA approvals of 2 RET selective inhibitors. So these are selpercatinib and pralsetinib. I think a defining characteristic of these drugs and the ones we're going to talk about next is that they seem to work better if given first versus if they're given after platinum chemotherapy. In the first-line setting, 80% response rate. If after platinum therapy, 60% response rate. And so the approvals are actually in a line-agnostic fashion. And in my clinical practice, I've always given them in the first-line setting. But there was a study called the Libretto 431 that was recently presented to definitively answer the question, should we be giving these over genotype-agnostic therapies such as chemotherapy plus or minus immunotherapy in the first line? And I think a lot of people ask, was this study necessary? Actually, it started at a 1-to-1 randomization, and they actually modified the design to have a 2-to-1 randomization later. About 75% of patients in the chemo arm went on to receive a RET TKI, so at least there was access to that. And because we're in March Madness, I don't think anyone would have selected kind of an upset pick here that chemotherapy would have beaten the RET TKI. And so not surprisingly, there was a doubling of the median PFS from about 1 year to 2 years, 20% improvement in objective response rate, both kind of intracranially and systemically. And so what we anticipated here, cementing this status as a first-line treatment. And so turning to...
Just go back to the RET for 1 second. I'm curious whether you think there are ever any diagnostic issues that maybe RET gets missed, and also whether you see any you're able to differentiate any difference between the 2 available RET inhibitors.
I think, with the emergence of NGS, I hope that RET isn't missed. And I think one of the things is RNA NGS, right? So fusions are easier to detect when you use an RNA-based NGS strategy versus a DNA-based NGS strategy.
That's why I brought it up. I mean, do you see people who aren't getting RNA-based therapy and have it missed?
They do. And I think that if you're using a commercial assay, like I don't work for any of these companies, but like a foundation or something, they have the bioinformatic pipeline for them to tile and kind of appropriately cover some of these using a DNA-based assay. But I do think that if you're using some kind of in-house assay, you might miss some of these RET fusions.
What do you do when you have a non-smoker, you suspect has mutation and you don't see it on NGS?
I start with the traditional systemic therapy, but I keep looking, right? And perhaps you cast a wider net with a bigger assay if you can.
And again, in terms of the two available RET inhibitors, any difference?
There's a little bit of a difference in the toxicity profiles, and so with pralsetinib, you see a little bit more of the cytopenias, and with selpercatinib, there's been a description of a hypersensitivity reaction that can happen, somewhat enriched in patients who received immunotherapy before they received the RET TKI. Both of them have a very odd toxicity that's rare, that's been described, chylous effusions, and so there's a kind of an emerging literature on this.
Kind of curious, Mine, have you seen patients with RET?
I did not see a RET, no.
Interesting.
Not yet.
Well, you'll be ready when it is. Okay, let's talk about MET.
Perfect. So MET, similar story, two drugs that work very well, approved around the same time. These are tepotinib and capmatinib. I've juxtaposed them, not as a formal comparison, but for us to digest the data. Again, the same theme. They work better when given first versus later line. In the first line setting, the response rate is somewhere around 57 to 67%. Later line, it comes in around 40 to 45%. First line setting, about a year for median PFS. These are great drugs in the CNS as well. And this has really been kind of recapitulated with real world data as well. What we tend to think about when we think about MET-targeted therapies, though, is the toxicity. We've talked about this a little bit with amivantamab already. The characteristic toxicity is really this peripheral edema, mostly grade 1 to grade 2, which can still be distressing for patients. Dose reductions with these drugs are seen in about 1 in 4 or 1 in 3 patients, and discontinuation around 10 to 15% of patients. And so when I think about the key toxicity considerations, so how do we mitigate or how do we ameliorate this peripheral edema? I tend to think that traditional strategies such as dietary changes, lymphedema therapy, et cetera, they haven't been as fruitful in my clinical practice. So dose interruption, dose reduction is probably the most efficacious strategy, and it is a reversible toxicity.
Before you go on, just to backtrack a little bit, you talked about both the RET agents and MET exon 14 as having good CNS activity. That model that we just talked about with using targeted therapy and holding off on radiation that we just talked about with EGFR, would you apply it to people with these two? And what about other, BRAF and other alterations? Are there situations, HER2, are any of those where you wouldn't use systemic therapy first?
I think the outlier would be what the group that Helena talked about, the EGFR exon 20s, just because the drugs don't have the CNS penetration. Some of the KRAS drugs, some do, but I would say overall.
BRAF?
BRAF, I think that they have demonstrated intracranial activity that's comparable to the systemic activity, but I'd keep a closer eye on those.
And again, capmatinib, tepotinib, any differences?
I don't think any drastic differences between the two have panned out.
Any, you think about these two really sensitive, and not to mention EGFR, any thinking about what the next step's going to be to sort of push us into the next level, so to speak?
Yeah, I think it gets tricky. With EGFR, we learned initially that there's that convergence on T790M that let us develop osimertinib. When people have studied resistance to MET TKIs, there's a variety of things that emerge, right? Sometimes on-target mutations, but also kind of MAPK pathway alterations, so BRAF, all sorts of things that aren't necessarily as actionable in combination with the MET TKIs, giving the toxicity of the MET TKIs already. So it's a tough one. Maybe an ADC might be helpful here, or a bispecific like amivantamab.
Please continue.
And so moving on to the final subset. So this is HER2 altered non-small cell lung cancer. I say that because we're starting with HER2 mutant, but we'll wrap up with HER2 overexpressing. And so this is a subset where we have a targeted therapy that's a little bit different. So it's an antibody drug conjugate, trastuzumab deruxtecan. It is approved at the 5.4 mg per kg dose, and that's based on the phase 1 study that identified a 26% ILD rate at the higher dose, prompting this study that's captured here. This is a TgtLung-02 study, not a formal comparison, so non-comparator cohort, but really to answer the question, at a lower dose, can we improve the toxicity and not sacrifice a lot of the efficacy? Answer is you can, so the response rate is about 50%, median PFS around 10 months compared to about 15 months with the higher dose, but importantly, half of the ILD rate that you saw at the higher dose and also half of the kind of dose reduction rate. I think a key thing that we saw recently at presentations is that this does have CNS penetration, right? So comparable intracranial efficacy to the systemic efficacy. There is an ongoing study to keep an eye out for. So this is a DESTINY-Lung 04 study testing chemo plus IO versus the trastuzumab deruxtecan. And finally, just talking about HER2 overexpressing non-small cell lung cancer with the caveat that we don't know what that is, meaning it's not something that we routinely query. And so this is an area where the definition is evolving just to show that this drug does have some activity here. This is the higher dose, the 6.4 mg per kg. Here we see a response rate of around 25%, median PFS of around 5 months. It does not necessarily seem that a 2+ expression versus a 3+ expression enriches for kind of more robust response. So the response rate is about 20 to 25%. Median duration of response is about 6 months in each of these subsets. And so I think it behooves us with data like this to more, as a field, more robustly characterize what is HER2 expressing non-small cell lung cancer and figure out if we can incorporate this into our biomarker testing paradigms.
So I'm guessing the IHT2+ doesn't have FISH with that?
Not necessarily.
So yeah, and that gets into the whole issue of TDXD, which I feel like we talk about all the time in many different ways. First, I'll start with you, Helena. What line therapy do you use TDXD? And let's say HER2 mutant, and why aren't we using it in HER2 overexpressing? I mean, just because it's not as good? 25% response rate when they're out of options doesn't look too bad to me, but anyhow.
Better than docetaxel for sure.
Way better.
I actually think that this will move. I think DESTINY-Lung 04 will be positive, and this will move to the first-line setting. I think there's just every oncogene we're seeing, use your best drug first. It works better, oftentimes can work better in the first-line setting. So I would think about this in the first line. And
in terms of looking and screening for ILD, again, we were talking about with the breast people, we were talking about, in different tumors, the types approach it differently. Ibiayi, how are you approaching it? Breast people are very aggressive about using scans in asymptomatic people, but then everybody's interested what you all do since your patients already have pulmonary problems.
Yeah, I think awareness, right? Making the patient very aware that this is a toxicity that can happen. A key is across the study, the median onset is 88 days, so within the first 3 months for this toxicity. So if they have a cough, dry cough that's not going away, they're huffing and puffing with their usual activities. And I think we're also fortunate in that we get routine chest imaging throughout a patient's disease course. And in many cases, it's an asymptomatic pneumonitis that you might pick up. And so those are the combination of those is my approach.
So Helena, am I ready for a case from the audience?
Let's do it.
Okay, this is from Nomen. 42-year-old, never smoker, stage 4 non-small cell lung cancer with brain mets at diagnosis. RET fusion on NGS, started on selpercatinib with good response, but after 4 months progression and with a MET mutation. Added crizotinib to the selpercatinib, did well for a year on the combination. Now with brain-only progression, multiple sessions of brain SRS, got laser interstitial thermal therapy, which you can tell me what it is. Also, repeat NGS, loss of MET mutation, but persistent RET.
It's complicated. I mean, it sounds like they did everything right in terms of you do something, you assess response, but also assess what drives resistance. I think at this point, you've kind of played around with the molecular and addressed the resistance to the resistance, so I think it would just be chemo. But agree with kind of the path that was taken.
There's another one that's pretty interesting from Rubiang Ibiayi. 67-year-old woman presents with metastatic non-small cell adenocarcinoma. NGS has a MET amplification, ERBB2 amplification, PD-1 of 70%. What are you thinking?
I'm wondering if they have polysomy, right? I'm wondering because MET and EGFR, like some of those genes are close together, and so sometimes you can get co-amplification of multiple things, and it may not necessarily be a focal amplification. So in that case, I might ignore those amplification events and favor a genotype agnostic strategy as the initial approach.
And just going back to that RET case, Helen, I wanted to ask you this thing about adding crizotinib, selpercatinib, but do we have data on that? I mean, patients stayed on it for a year.
Yeah, I mean, I think that I haven't heard of data in RET, but certainly in EGFR, adding, when we see acquired MET amplification, adding the MET inhibitor to the drug, the TKI targeting the driver, I think we've seen does actually, lead to responses and pretty durable at that.
So I've got to ask Ibiayi, laser interstitial thermal therapy, what is that?
I was hoping you'd ask.
I was like, thank goodness.
It seems like some sort of local therapy. That's all I have.
Well, good to know. Anyhow, maybe whoever, you could tell me about it and we'll bring it back up tomorrow. But thanks so much. We're going to move on and talk about non-targeted therapy.
Thank you.